gravity sign is actually putting them in about a 90-degree position here and looking at the tibia to see if the tibia tuberosity is posterior relative to the so when the patient's relaxed, they will actually have the tibial tuberosity, or the proximal end of the tibia, stop that, will be more posterior. You're stealing my show here.
Different tests. That's different tests.
Yes. So PCL looks okay to me in this position. So I might do it in both. I might go, okay, just relax. All right. That looks okay. I might even put a goniometer edge across it to see if it's straight. Normally, when it's unstable, you'll see that tibia drop lower. There'll be a shelf. You take your fingers across the tibia and you'll hit the patellar pole, inferior patellar pole, or the apex of the patella, because it's not in line with it. Okay. I've only seen it twice. And I knew they were torn, so it wasn't like I discovered it. I did the test on a person who I known was confirmed to be torn to see how reliable the tests were. And so that's really fun because it's like the gold standard. It's like you already know that person has a slap, you already know that person, whatever. If it's okay with them and if they just didn't have a surgery or something, go ahead and do the test for instability on it. And then see, you want to feel what abnormal is. It's the best way to do it. Okay? So, what is so funny?
He's just wiggling his tibia.
He just keeps wiggling. Okay. So again, we're just in straight planes now, and then we're going to go into the rotary instabilities. So the anterior drawer is basically, you take the tibia and you pull it anterior. Okay? And the posterior drawer is you take the tibia and you push it posterior. Again, the tibia is sitting like this, so the direction of force is like this for anterior drawer, not like this. So you pull this way, away from the penis. You pull up, you're going to bang the tibia into part of the femoral condyles and get an accurate test. Okay? Now, again, different variations of this. One thing that's important is your fingers are coming around the posterior part of the tibia. I'm going to go up into the hamstring tendons. Okay? So semitendinosus and gracilis. Semitendinosus I can feel really well right on the medial side. And then biceps femoris on the lateral side. And that's really important that they're relaxed. Why? Because those things flex the knee or create posterior tibial translation. So if they're guarded, then you're not going to get an accurate drawer. Okay? Because the hamstrings will limit the glide of the tibia anteriorly. This is a draw. It's a stop it. This is a draw, and that you're sort of grabbing it and dragging it. You're not doing a quick, okay, high velocity, low amplitude thrust. So the difference between these drawers is you're looking at total excursion. That's why the sag test or gravity test is more important with this one. Because if it's a posterior cruciate and it's already posterior and you keep pulling, you're going to think that excursion is way too far when the anterior excursion is fine. In contrast, the Lachman's is an end-field test. Do they have an end field or not? You're not looking so much at how far it goes before it happens. Do you feel the snap or not? Okay? This is kind of a way to grade that.
That's right. That's a really good point. Remember, Lachman's is either positive or negative. You don't grade a lot, positive or negative. This you can actually grade the drawer, like Paul said. It's an excursion test. You need to compare difference of joint displacement from right to left. Lachman's is either positive or negative. You don't have a grade 1, grade 2, or a grade 3 Lachman's. It's either positive or negative.
So I'm sitting on the foot to block movement or motion of the tibia below. I put my posterior lateral thigh against their foot in a neutral position, so slight toe out. Okay, not like this. External rotation, not like that. That's for later. Right here. Okay. And I sit on it so it doesn't slide. Palpating behind to make sure the tendons are relaxed. And I like to put my thumbs on the tibial tuberosity on either side of the patellar tendon. Okay? Sometimes people will bring their thumbnails up toward the femur so they get an effect of feeling how that tibia plateau goes forward over. He's unstable here, so how's your left one anterior, posterior? Okay, so let's do that, let's do that. That first. No, sorry, just kidding. Okay. It's more guarded. I'm just gonna do an excursion there. Okay,
Hey, Paul.
that's pretty
Just a
loose.
suggestion. Can we move the table, kick the foot of it out about 30 degrees? Because then I think the camera would give us a really good appreciation of this displacement.
I don't know that.
There you go. Yeah, that'll be good. You better drape them though. You better drape them though.
Glad we have wheels.
Yeah. I can see it's hog right now. Still burning my memory.
So, I'm just gonna grade that, and that tibia is coming about half a centimeter or so forward underneath the femur. That's lax. If I felt that, I'd wanna know what's happening with the ACL. He's got a positive, he's got a negative Lockman's. That's okay. Nice, good snap. Point, point, point. Okay? All right, so that's okay, but he's a little lax, all right? Now, if he had collateral ligament damage, he might still allow for more anterior translation there. So I'm wondering, how come he's so lax if his Lockman's okay? Whoa! That's soupy right there. That is just, he is like no MCL there. You go like this, and you see a little invagination right there where that scar is. It's, if I pushed harder, you'd probably hear it pop.
Sulcus at the knee.
It's a sulcus at the knee. That's what I was getting ready to say. Okay? And varus not as bad. So I'd say he's got a full disruption of the MCL on the left. Maybe stretch the LCL on the right, but on the lateral side, on the left. Full disruption, grade 3 MCL, totally gone, right? Yeah, okay. That's what that looks like. That's good to see. Don't do that too much on the eye, but you can see, and if you were to feel that, it was more than my finger width of a gap. Okay. So that's why he's got that anterior drawer. Now, I'd want to know, MCL, what would he expect to have more instability? Anterior medial rotary instability or anterior lateral rotary instability?
Anterior lateral.
Anterior lateral. So if the MCL was torn, maybe the posterior medial side, that's going to allow the medial tibia to go anterior better. It'll be an anterior medial rotary instability.
Yeah, I think, go ahead. Go ahead.
Because that's the side of the instability.
No, you just went, yeah.
Anterior medial.
Yeah, you celebrate.
Remember,
Yes, I think so.
collaterals,
No, he said anterior.
the primary stabilizers for varus valgus, right? And the cruciates become secondary stabilizers for varus valgus. But the collaterals are secondary stabilizers for anterior posterior. And if you got the MCL that's torn, and you just saw that. You had increased valgus play and also increased anterior displacement, right? So what you're seeing there is part of that contribution. The MCL is not holding the tibia back. So it plays a really important role. It'll make a little bit more sense as we move on with some more testing.
And I bet his posterior medial compartment is torn, and he probably has a posterior horn meniscus tear that was cut out a few years ago too, right? Hey, pretty cool. So, sucks for you.
Would you expect more rotation at the tibia because he's, so when you did the Lockman's, would you have like some rotation component to it?
Yeah, but the Lockman's is just a straight, if I'm doing the Lockman's correctly, I wouldn't let that happen.
Right.
But the Slocum test does just that, and we were gonna cover that, but I was just gonna do a straight plane mode. But now since we said that, so I think he had a positive valgus test. And this is how I do it with my patient, all right? Negative sag, I haven't done posterior drawer, I do posterior drawer, I'll show that in a minute. Negative Lockman's, positive valgus, maybe a little varus stress is positive. Medial compartment, something's the matter. Now, if I want to see if there's a rotary instability, I will create an unstable situation and see how well the ligaments check that movement. So if I think he's got an unstable medial compartment in the anterior direction, because the anterior drawer was positive, I will put him in this position. I bring the tibia, the medial aspect of the tibia, anterior, okay? On a normal knee, that should be pretty well stable. If you externally rotate the tibia, even if it's not in full extension, the ligaments should tighten up of the MCL, and the posterior medial capsule should tighten up and limit the drawer sign. So it should be pretty solid. If I pull on it, it keeps coming. So he's got an anterior medial rotary instability right there. I check, I bring the tibia more lateral, or more anterior on the lateral side and pull. That's unstable too. Okay? So he's got an anterior medial and anterior lateral rotary instability. This guy's a mess.
Well, shut up. I'm not held up.
So, you okay with that? Okay. He's okay. So, does that make sense? All right, so that was the anterior drawer. I did it on the left side.